Hemophilia, a project by Adam, Bella, Emilio, Maria, and Kaylin. First off, what is hemophilia? Hemophilia is an inherited blood disorder that impairs the body's ability to be able to make clots, a process by which is used to stop bleeding. Symptoms include nosebleeds, bruising, blood in stool or urine, bleeding after vaccinations, bleeding from mouth or gums, etc. This disorder causes people to bleed for longer periods of time after surgeries or injuries in comparison to those without hemophilia. It can be caused by a mutation within a gene that is supposed to provide information to prevent the making of blood clots. The genes are present in the X chromosome. Hemophilia occurs in about 1 of every 5,000 male births and is rare in females. The genetic mutation which causes hemophilia is a recessive change in the X chromosome. Males have 1 copy of the X chromosome genes, while females have 2. Therefore, males have a 50% chance of developing this disorder if their mother is a carrier of the mutated gene. Females can only inherit hemophilia if the affected gene is in both X chromosomes. The 2 major types of hemophilia are type A and B, which occur due to lack of clotting factors 8 and 9.
The current state of knowledge regarding hemophilia. The most common type of hemophilia is called hemophilia A, in which it is caused by a lack of clotting factor 8. Factor 8 is essential for the formation of blood cells. It is produced by the liver sinusoidal cells and endothelial cells, but circulates around the body in its inactive form, bound to another molecule called von Willebrand factor. Factor 8 separates itself from the von Willebrand factor and will set off a chain of additional chemical reactions that form a blood clot. Hemophilia causes mutations on the F8 gene, the gene that acts as the producer of factor 8. In this case, hemophilia will cause mutations on the F8 gene in that it will produce an abnormal version of the protein or reduce the amount of protein produced. Either way, it is affecting the clotting process. Hemophilia can be mild, moderate, and severe. This is predetermined by genetics, and severe is the most rare. This can be diagnosed while the mother is pregnant, in the first year of life, or in adult life. It does not change, the severeness does not change throughout adult life. It is a rare disease but can be dangerous and challenging for those that have it.
Hemophilia is usually passed down from generation to generation, but in rare cases it can be acquired without any family history of the disease. Such cases are more difficult to diagnose because other bleeding conditions may coexist, but are often associated with pregnancy, autoimmune conditions, cancer, multiple sclerosis, or the effects of some drugs. Either way, it can lead to severe internal bleeding, joint damage, and viral infections like hepatitis C. About 70% of cases cause massive blood loss, and 5 to 10% of cases are fatal. About 1 in 5,000 babies in the United States are born with hemophilia A, which is the most common type. The number of cases is unknown, but believed to be at least 33,000.
The most prominent controversies regarding hemophilia are the treatments given to those who have it. I'll be discussing the controversies in 2 of the treatments given to patients with hemophilia up till now. The first of which are extended half-life products. These are also called EHL products, in which they help patients' 8 or 9 factors stick around longer in their blood. The pros of these are that they have reduced injection frequency, so it stays longer in the bloodstream. It has increased treatment adherence, which means the patients actually uphold and stick to the treatment. It's laboratory made, so there's no infection risk. It has improved clinical outcomes and allows for individualization in treatment. The cons of this, though, is it's only meant for severe hemophilia A and can have some side effects such as headaches and joint pain. The second one is known as a non-factor therapy, exizabub. It serves the purpose as an 8 factor by connecting factors 9 and 10 and helps the process of coagulation. It's the first highly effective treatment for patients with hemophilia A with inhibitors. The pros are that it showed decrease in bleeding events overall, and it can be used for patients with and without inhibitors. Unfortunately, though, it is not able to achieve normal clotting as you would with EHL treatments. It can only be used as a preventative drug. It's not supposed to be used for acute care and it's only for severe hemophilia A.
In August 2022, the European Union approved the medical use of Roctavian, or Volocto roxaparvovec, a form of gene therapy for the treatment of hemophilia A. As mentioned prior, hemophilia A is a bleeding disorder that results from mutations in the F8 gene, which codes for the factor VIII protein essential for the clotting process. Patients with hemophilia A produce too little factor VIII or an ineffective version of the protein. As stated previously, Roctavian utilizes gene therapy by using an adeno-associated virus, which codes for human factor VIII. For added context, AAV are known to not cause disease and cause a very mild immune response, making them the attractive candidate for viral vectors for the usage of gene therapy. Roctavian, paired with a human liver-specific promoter, will encourage translation in liver endothelial and sinusoid cells, which in turn will transfect a functional version of the F8 gene into the cells and make the patient produce sufficient amounts of factor VIII biologically. While the European Union has approved medical use of Roctavian, we must ask, what about the United States? The Food and Drug Administration, the agency which oversees protecting and promoting public health through the control and supervision of food safety, medications, vaccine, etc., in the United States, had thought otherwise. In August 2020, the FDA sent a complete response letter to BioMarin, the company which oversees Roctavian, stating that the application that would have made Roctavian the first gene therapy to be approved for a bleeding disorder no longer approved, suggesting that the protective effects wore off approximately 12 to 18 months, along with significant and dissimilar differences regarding the durability of the drug. All hope is not lost. The FDA advised BioMarin to resubmit a 2-year follow-up of evidence of safety and effectiveness. With some leeway, the earliest evidence may be submitted in early 2022.